Hello, good afternoon, and thank you, Oliver and John and the organizers for having me speak. And this is something completely different. After all that talk about exit velocities and cyclotrons, now we're going to the other extreme of medical technology surveillance, conservative management for low-risk prostate cancer. Okay, so can I have the first slide? Or I do it here. Okay. So how do I maintain active surveillance? So I thought this was a good good topic to take here. Thought I'd talk about active surveillance. This is something that I do as a prostate cancer oncologist, but also put it in context of really a lot of recent studies, sort of updated studies of cohorts, and then talk about some of the big questions that I see taking care of these patients. So again, going back and forth between sort of cutting edge research and very practical advice. Okay, disclosures. So what's the rationale for active surveillance? So is really that the prostate cancer is so common in old men. Here, the shaded bars represent prostate cancer found usually clinically occult at the time of death for another cause. So you can see, depending on the age of the patients, as many as 50, 60% of men will have clinically occult prostate cancer at autopsy. And then this is the other rationale, this issue of competing risks for prostate cancer. Many times prostate cancer is diagnosed in older men and they succumb to death from other causes, non-prostate cancer causes. So here, looking at these graphs, this is how many years, up to 20 years. The shaded is death from prostate cancer in a cohort of conservatively managed patients, and the white represents alive, and then the light gray is death from other causes. So depending on the age, depending on the grade of prostate cancer, the risk of non-prostate cancer death significantly increases prostate cancer death, even in these men diagnosed with what might be called clinically significant prostate cancer or Gleason 6-7 prostate cancer. Okay, so so again, most men will die from non-prostate cancer causes, and so surveillance seems like an appropriate management plan, but we really have to think about this issue of competing risks. So we have to try to really, as precisely as possible, determine what's the risk of prostate cancer related complications, and also some idea about the overall risk for death from other causes. So if we're really going to balance this as we approach our patients, we should be able to look at both sides. So first about risk prediction in prostate cancer, it's obviously a huge field about prognostication, but overall, very common clinical variables used, PSA, the Gleason score, the tumor grade, the tumor stage, and then also increasingly some idea about about volume of cancer, number of cores positive, percent core involvement, something like that. And so this is a very common index that's used, the UCSF CAPRA index, but those are just basically the variables, and you can separate patients that will have a very good or poor prognosis based upon that. So that's the main clinical judgment that we use. And then that's really been interpreted into guidelines, put into guidelines. This is the NCCN guidelines about sort of the use of active surveillance for low-risk prostate cancer. So basically what the NCCN did was they separated low risk and then they subdivided it out again into this criteria called very low risk, which is also basically what's called the Epstein criteria. So these are patients that have only Gleason 6 disease, less than 3 cores, a low PSA density, clinical T1C, so just non-palpable prostate cancer. Those patients have a very, very low risk of developing cancer-related complications or death from prostate cancer. And then the conventional low risk, which is again more like the D'Amico criteria, they have those two, these three main factors. You could have a palpable tumor, but the Gleason has to be 6 or below, and the PSA has to be 10 or below. And then the NCCN separates it based on survival. So they talk about the expected survival. If it's less than 10 years, basically you should only observe those patients, which is to say no surveillance. By the NCCN, it means like, I'll see you later, if you have a back pain from prostate cancer or something, let me know. But no surveillance, no PSAs, no active follow-up on those patients specific for cancer. Active surveillance is the other factor here. That would be basically usually some protocol of regular follow-ups, maybe with repeat biopsies. And then if they have very long life expectancy, we could throw in active surveillance with radiation, with radical prostatectomy. So the thing that always struck me about this is, okay, well, how are we supposed to get this middle column here? How are we supposed to figure out how long does anyone have to live? As the patients often tell me, I'm certainly not a deity. So how do we do that? So this is how the NCCN guideline would have us do it. So they'd say, okay, go to the life expectancy tables at Social Security and put in your patient's age, and then you'll get the life expectancy. So a baby is born from the 2010 census data, has an average age of 76, a male baby. But then as they get older, their life expectancies obviously go down, but the overall life expectancy goes up. And they're approaching this like 80, 82, 85 years, depending on how old they are. And then, okay, that seems very life insurance-like. As a physician, we like to use judgment. So, okay, what's the judgment? It says, well, if you think that they're in the best quartile of health, which is not defined, you add 50%. So, 14 years becomes 21 years. And then if you're in the worst quartile of health, then you subtract, 50%. So, so 14 years becomes 7 years. So I think it's really all over the place, this issue of risk prediction. There's obviously much more complicated ways to do that I think no one will do outside of an electronic medical record button. But looking at other performance status, independent activities, daily living, stuff like that. But basically, this is sort of one of the official US-based guidelines. So using this data, there's just very recently in the JCO in the last year, really two large cohorts or updated results of cohorts of active surveillance patients. So I thought I would take a couple minutes reviewing those articles in Journal of Clinical Oncology, because these are really the best described, longest follow-up cohorts of active surveillance that we have. And so the first one was from Abal Carter and colleagues at Johns Hopkins, where they looked at almost 1,300 men treated with active surveillance. Median follow-up was 5 years. Their median age was 66. And the entry criteria, by and large, was this very low risk, something like in the NCCN guidelines, or almost essentially exactly. And about 29% were what are called low risk. So again, they could have palpable disease, but no Gleason 7s. And so this is the long-term follow-up data that, again, was just reported. So in the blue line is overall survival. So overall, of course, the patients that are age 66, they're likely going to live for at least another 15 years on average. Most of them did, but some of them died from other causes. But in terms of prostate cancer-related mortality or developing a metastatic disease, that's the yellow line way down here. So there's a 99% metastases-free survival. So, of course, with the selection criteria, which is a pure clinical selection criteria, the patients did very, very well. And in that sort of 10-year time frame, essentially no prostate cancer-related complications, except for, I think, just a very few number of patients, 2 or 3 out of the 1,000 or so. So the other risk of active surveillance is what's considered, a conversion or a reclassification. So someone who's in surveillance that subsequently goes off and goes on to some sort of active treatment, radiation or surgery. So you could look at in these cohorts, okay, what's the risk of that? So a lot of that has to do with how are they monitored. So the typical monitoring is a PSA every 3 months or so, and then another biopsy, or what's called a confirmatory biopsy at maybe about a year. That's sort of a very common monitoring protocol. And then every group, every cohort, every publication has different criteria for what's called progression or reclassification. In the Johns Hopkins cohort, it was the Gleason greater than 7, so any Gleason pattern 4 or above was considered progression, greater than 3 biopsies, or any core greater than 50%. So the last two, we're looking kind of at the volume of the cancer, even if it's low grade, and then the first looks at kind of some sort of upgrading risk, the risk of a Gleason 6, because they're all 6 going to a 7 or above. And in that overall in that cohort, again, a median follow-up about 5 years, 1,300 patients, about 36% of patients were reclassified or basically went on to active treatment or some recommendation for active treatment. So this is the sort of the curve of that, showing that, again, overall at 10 years, maybe about a third of patients actually go on to some form of treatment. Why do they do that? About 2/3 of them are for some reclassification, some upgrading or increased tumor volume. But again, about a third of patients go off just because of patient preference. They get tired of getting a PSA, they get tired of a repeat biopsy, they get anxious, their wife brings them to the radiation facility, whatever. So about a third of patients go off for other reasons. So there's definitely a risk of sort of reclassification, which is in a lot of ways more like a delayed therapy in these surveillance patients. Okay. So the other big publication, the other really leading group in active surveillance was here in Canada, University of Toronto, with Larry Klotz and colleagues. And so this is, again, their publication also in the JCO this year. About 1,000 patients. Median follow-up was 6 years, but many of the patients went out to 10 years. The entry criteria was different than in the Johns Hopkins cohort. So, and it changed over the course of the trial, but basically the sort of current or the most common entry criteria was this. So they had low risk prostate cancer, so Gleason 6 or below, or PSA less than 10. But again, they could have a palpable tumor that had nothing to do with, so, and no consideration for what we would call sort of tumor volume, percent core positive, something palpable, anything like that. But then also they had this other thing that they called favorable intermediate risk. So I like how we went from low to very low risk, and now this is intermediate risk, but favorable intermediate risk. So we definitely like our shades of gray in oncology, and this is one of them. So here the PSA could be 10 to 20. They could have a Gleason pattern of 7, though it couldn't be the predominant pattern 4. And then they had to have a life expectancy of less than 10 years. So again, that begs that question of how are we predicting life expectancy? I don't know what the Canadian equivalent of Social Security tables would be, but I imagine it would look pretty similar. All right. So what was their outcome? So again, overall in the patients that stayed on, there was almost a 10-year median follow-up. The survival was 80%. The metastasis-free survival, very favorable, 97%. Intervention occurred in only about 27% of patients, which is less than in the US cohort. But many of the interventions was because initially in the early phases of this cohort, they looked for PSA doubling time, and at some point they decided, look, PSA doubling time is not an important factor for criteria, which other studies like Johns Hopkins have shown that the PSA really shouldn't be a trigger for intervention in these patients. So that was removed. And then basically the risk for reclassification in the later cohorts had to do with, or then they looked at what are the risks for reclassification, and patients that were younger so they had more follow-up, palpable cancer, the Gleason 7s more likely progressed in some form, high PSA, number of cores, and the presence of prostatitis. So these are the risk factors for at entry that they would develop, go on to active treatment and in a way kind of, quote, fail active surveillance. So in terms of the management, what are some of the appropriate questions? So who are the candidates? And again, what I've alluded to is this issue, are any Gleason 7s allowed to be included, or should we look at how long they have to live? And also the tumor volume, if you could feel the tumor, is that still appropriate, or should we only restrict it to T1C and below? So what can we use with sort of more modern technologies to help answer some of these questions? Well, one would be imaging, and multiparametric MRI is really at the fore of this. So multiparametric MRI is not only the T2 weighted imaging, but apparent diffusion coefficient and dynamic contrast enhancement used to better define an area of abnormality within the prostate. So increasingly it's being used in the initial evaluation. It can better define low-risk disease. So one study that looked at this, patients that were otherwise maybe candidates for surveillance, low risk prostate cancer, if they had a lesion on the MRI, they were more likely to have, if you could see it basically on the MRI, they were more likely to have, quote, clinically significant low volume disease or low risk disease at surgery versus no MRI lesion. So here are the ideas that the MRI, if it's large enough that you can see it with the multiparametric techniques, then it's more likely to be what would be called clinically significant. And again, clinically significant may mean those patients shouldn't be on surveillance, but there's really quite a few hypotheticals in that chain of statements. So I would say also that there's a UK guideline that recommends multiparametric MRI for patients considered for active surveillance. Again, here the idea is, well, maybe we haven't adequately sampled the tumor using just a standard expanded sextant approach. The MRI would be better able to define any missed large areas that could be, quote, clinically significant. So this is the kind of the state of the MRI for imaging. Patient selection. What about other markers? So there's a whole plethora of genomic tests that you could look at. PSA, factors, tissue, urine, PCA3, blood isoforms. Again, these are basically very good to look at cancer versus non-cancer, but could they be used to look at high-grade cancer versus low-grade cancer? Some data, but generally not very strong. This I'll skip for time. Again, so patient selection, if you look at these other PSA isoforms, which again are helping to determine if a PSA is elevated, is it cancer or non-cancer, but much weaker at the ability to predict, quote, clinically significant cancer. So that's true for the genomic tests like Oncotype DX, but it's also true for these biomarker tests like a 4K score and PHI and others. Okay, is there an optimal monitoring protocol? So again, about anywhere from a third to a half of patients progress during some period of active surveillance. Can we predict who that is? So I thought this is a really interesting paper that's in press in European Urology still, but I thought it was really fun. So you can put into this nomogram, which is available, the age, how much time since the last biopsy, the PSA, the percent core involvement, and then it prints out for you, presumably that you would share with your patient 100 little happy faces. What's the risk that if you do another biopsy on surveillance that it is somehow progressive? And this is using the Canary Pass protocol as another surveillance cohort, so it's a little different criteria, but basically some version of clinically significant disease. It's about, again, in this thing, about 23 out of the 100 patients, and then also the risk of the biopsy. So there's the little thermometers that represent the risk of sepsis after the biopsy, so about 2%. So this is kind of a fun visual that looks at the risk of surveillance, or certainly surveillance biopsies. And then one might ask, okay, well, we have these tests, they are MRIs and urine PCA3s and whatnot. Can we use these to better determine who should get surveillance biopsies or how many or when? Again, the data is very, very poor. MRI has really not been shown to be helpful, but I know we often do it and others do as well. Urine tests, there is some data. Scott Tomlins, if he's around, could comment on the use of urine PCA3 and TMPRSS2. There is some data, again, in this Canary cohort that showed that it was useful. Again, the prostate health index, a little bit of data, but really not so strong. So what are the challenges? So I would just say the challenges have to do with how do we approach clinically significant disease? Is all Gleason 7s are appropriate or not, or none? How do we image them? How do we monitor the patients? This issue of reclassification is important. There's different criteria and different protocols, but it's pretty random. And also thinking about it doesn't mean death from prostate cancer when you get reclassified. It just means that it's a potential related to clinically significant disease, which may potentially relate to some complication later on. Again, I think we're never really going to know that more than the surrogate of clinical significant disease. And then the summary, as we talked about, it's very reasonable for patients with low to very low risk. In the Toronto cohort, they even looked at the Gleason 7 tumors with less than 10-year life expectancy. We really have to get better at selecting these patients. There's this risk of conversion, which I would say is pretty high, 50% in the US cohort, and that the biomarkers to better determine how we should follow patients on the surveillance, I think is a really important need. I know that patients and physicians would like to have filled. That's it. Questions?
Great. Thank you, Mitch. The yeah, huge issue today. I mean, so many patients are candidates. The academic centers, I think, warrant surveillance cohorts are virtually everywhere now. Private practice, still not so, and a lot of patients, particularly if they have that IMRT facility. I don't know. Any comments, suggestions? And if not, we are going to try to continue on at 5. And so we've got a break till 5. I think there's supposed to be some snacks out there if you want a snack or go take a walk. What's that?
Yeah, I think Dr. Reiter is going to talk about imaging. No.
Are we, Rob, did I miss? Hang on. No, okay. No, that's quite interesting. I had already flipped the page. It was intended to be a direct insult to my friend Rob Reiter. Rob, let's